Yes, sir. We started recording, sir. Thank you.
Okay. Good evening, Mayowa and every other member of the YNNF and our senior colleague here present. Welcome you once more to the June edition of our webinar. And like the president of the YNNF has said, today's webinar will be anchored by the team from the Nnamdi Azikiwe University Teaching Hospital in the Navy, and we would have our faculty to be revealed as we proceed deep into today's webinar. To start off, today's topic is lumbar spondylosis, and we have the subtopics as published case presentation, relevant anatomy, pathology, and then we'll look at the clinical aspect of the management of patients with lumbar spondylosis. We have two speakers from NIUT. The first speaker is Dr. Chukudima Kafo, and the second speaker will be Dr. Raphael Nwosu. I know would have a very engaging and exciting presentation from the team from NIUT. So if Dr. Chukudima Kafo is ready, we would like to get today's webinar rolling. Over to you, Dr. Chukudima Kafo.
Good evening, professors, consultants, and colleagues. I'll be taking this the first part of this YNF webinar anchored by Nait Navy. I'm Okafor Chukudima, and my colleague, Dr. Nwosu Raphael, will be taking the second part. I'll take the case presentation, the relevant anatomy, and pathophysiology. This is my outline. For the case presentation, my patient is Mrs. A.E., a 63-year-old right-handed unemployed woman who hails from Okija and resides in Nnewi in Anambra State. She's a Christian of Roman Catholic denomination, highest educational qualification is SS1, and she was my informant. She presented with low back pain of 5 years duration. Her problem started 5 years prior to presentation with low back pain, which was insidious in onset, dull in character, aggravated by working with no known relieving factors. She finds it difficult to carry on with her normal daily activities on account of the pain. Problem continued to worsen with associated intermittent claudication, numbness in the lower limbs, and muscle cramps. Her claudication distance was estimated to be 20 meters. She also has urinary urgency and constipation. There was no history of persistent trauma or low back pain before the low back pain. There was no chronic cough or contact with the chronically coughing adult, no drenching eye sweat, no breast masses, no passage of blood in stool. She has no weight loss and no anorexia. On account of her problem, she visited a specialist orthopedic clinic where she was receiving steroid injections as she initially declined surgery. When her condition worsened, the patient accepted surgical intervention and was referred to a neurosurgery clinic for continued care. She was not a known hypertensive, diabetic, asthmatic, epileptic, or sickle cell disease patient. No previous surgery or blood transfusion, no known drug allergy. Other aspects of the history were not contributory. On examination, I found a woman in obvious distress, afebrile, not pale, enteric, not dehydrated. Vitals were stated, and her Glasgow Coma score was 15. Pupils were 4 mm bilateral, briskly reactive to light. Power was grade 5, no muscle groups of both upper and lower limbs. She had normal tone and reflexes, but she was working in a stooping position. This straight leg raise test on the right was 70 degrees, while that on the left was 50 degrees. The available lumbosacral MRI she did revealed normal lumbar lordosis. There was pan disc dehydration as evidenced by the darkening of the intervertebral discs, multi-level posterior disc prolapse, and hypertrophy of ligamentum flavum, causing canal and foraminal stenosis. And these abnormalities were most marked at L4, L5 level, followed by L3, L4, and then L5, S1. She had normal vertebral body height, and there was no spondylolisthesis. So we made a diagnosis of lumbar spondylosis disease with canal stenosis and radiculopathy. She was worked up for surgery, cancelled, informed consent gotten, few investigations were done, and the anesthesis reviewed. She had L4 and L5 decompressive laminectomy, and L3, L4, F4, F5, and L5, S1 bilateral foraminotomies. In the post-op period, she received IV fluids, analgesic antibiotics, was nursed in the right and left lateral position to avoid the posterior midline wound. Post-op full blood count and history were equally done. She had an uneventful post-op recovery. Bilateral lower limb physiotherapy was commenced few weeks after the surgery. She was discharged after structure removal on an outpatient basis. Currently, patient is able to ambulate without any form of support. For the introduction into our topic, I want to say that spondylosis is a non-specific term used to describe the degenerative conditions affecting the intervertebral discs, vertebral bodies, and associated soft tissue and joints of the human spine. Other terms used interchangeably with spondylosis include the spinal osteoarthritis, spondylosis deformans. The three important components of this disease entity include degenerative diseases, degenerative spinal stenosis, and acquired spondylolisthesis. Spinal stenosis is defined as a narrowing, abnormal narrowing of the vertebral canal, and is frequently caused by degenerative disc disease, while spondylolisthesis specifically refers to forward translation of one vertebra relative to its neighbor, the adjacent vertebra. Lumbar spondylosis is present in more than 80% of people aged 40 years and above, but most are symptomatic or present with mild symptoms. A good understanding of the structural architecture, mechanism of function of the lumbar spine, coupled with a good knowledge of the pathological mechanisms of occurrence of this disease entity will greatly support its treatment. For relevant anatomy, the lumbar spine consists of 5 large mobile vertebrae numbered from L1 to L5 in the craniocaudal axis with their intervening intervertebral discs. Certain angulation of lumbar spine is defined as 20 to 25 lumbar lordosis. The lumbar vertebrae, last coastal facets and transverse foramina, distribution them from the thoracic spine. Each vertebrae consists of a vertebral body, neural arc, and bony processes. The lumbar vertebrae have strong bodies that were designed for axial load bearing of the vertebrae above and the body weight. They also have a stout and robust neural arc for protecting the cord and nerve roots, while the processes are for bony articulation and efficient muscle action. The lumbar spine has the spine's largest vertebral bodies, so I mentioned before, which increases in size from L1 to L5. The kidney-shaped bodies have vertical height that is greater than their transverse diameter. Adjacent vertebral bodies are connected by intervertebral discs, which are actually fibrocartilaginous joints. They also have neural 2 pedicles, 2 laminae, and a spinous process. The pedicles are actually robust with transverse diameter being larger as you move from L1 to L5. The transverse diameter of the pedicle range from 10 millimeter to 18 millimeter. And the transverse pedicle angles increase from 0 at L1 to 30 degrees at L5. The vertebrae, that lumbar vertebrae, is also composed of one spinous process, 4 articular processes, and 2 transverse processes. The inferior articular processes of the lumbar vertebrae are posterior and medial to the superior articular processes, which are actually anterior and more lateral. The concave superior articulating processes face medially and somewhat posteriorly, while the inferior ones face laterally and anteriorly. Inferior ones are convex, while the posterior ones are concave. The facet joints of the 1st to the 4th lumbar vertebrae are oriented in sagittal plane, allowing flexion and extension, while resisting rotation and lateral bending of the lumbar spine, while the facet joints of L5 S1 is oriented in the coronal plane, facilitating rotation while resisting anteroposterior translation. This, I don't know whether my cursor is visible, but let me continue. The 2 transverse processes project laterally, actually size of attachment of the deep back muscle that supports the lumbar spine. The intervertebral discs that separates the vertebral bodies form a fibrocartilaginous joint that allows flexibility and weight bearing in the lumbar segment. Each intervertebral disc is composed of nucleus pulposus, annulus fibrosus, and cartilaginous end plates. The annulus fibrosus consists of 10 to 12 concentric layers of fibrous tissue and is weaker posteriorly because the fibers are more numerous both anteriorly and laterally, but deficient posteriorly. The posterior longitudinal ligament provides a weak midline reinforcement for the intervertebral discs, especially at L5, L1, and L4, L5, and L5, S1. The nucleus pulposus is predominantly composed of water and aggregans, which consist mainly of proteoglycans in a gel-like matrix. This nucleus pulposus is semi-liquid in childhood, but as an individual ages, they become more solid and fibrous. The intervertebral discs observe the functions of load bearing, maintaining spinal stability, and controlling movements between adjacent vertebrae. They also have to hold the foraminal spaces open and prevent the compression of the exiting nerve roots through the neural foramen. For the ligaments of the lumbar vertebrae, the anterior longitudinal ligament covers the anterior surface of the lumbar vertebrae and is attached to the anterior aspect of the annular disc and resists spinal extension, while the posterior longitudinal ligament located over the posterior surface of the vertebral body, that's in the spinal canal, it inhibits flexion of the vertebral column. The posterior ligamentous complex for additional stability of the lumbar vertebrae consists of the ligamentum flavum joining lamina, the supraspinous and intraspinous ligaments, and the intratransverse ligaments that join adjacent transverse processes. This posterior ligamentous complex supports spinal stability, resisting all forms of excessive movement across the intervertebral joints. The caudal end of the spinal cord extends to the level of L1 in the adult, but below L1, the spinal canal contains the descending lumbar and sacral rootlets, collectively known as the cauda equina, just as you can see in this image. Each lumbar and sacral root exits the dural sac laterally, approximately 1 vertebral level above where it will exit the spinal canal. That's the L4 nerve root will exit the dural sac at about L3, L4 intervertebral level. But the nerve root that travels will later travel far laterally to exit caudal to their respective pedicle. That's the L5 root will exit at the L5 S1 intervertebral foramen. The lumbar vertebrae is supplied anteriorly by a paired group of nerves arising from the aorta, opposite L1, L4 body. The fifth pair of arteries arise from median sacral body or from the lumbar arteries. Ascending and descending branches are anastomosed and supply the vertebra, the meninges, the nerve roots, and the spinal cord. Okay. The intervertebral discs, they have good blood supply up to the age of 8 years. Thereafter, their nutrition is mainly through diffusion from the vertebral body or from blood vessels on the surface of the annulus. Venous drainage is via internal and external venous plexus that drain into the lumbar segmental veins. For epidemiology, lumbar spondylosis occurs in 6 to 10% of the general population. More than 80% of people aged greater than or equal to 40 years have been known to have lumbar spondylosis. While among athletes, 25 to 60% of athletes will have lumbar spondylosis. 3% of people aged 20 to 29 years have lumbar spondylosis, while 7 to 75% of people with low back pain will have lumbar spondylosis. According to Boden and his colleagues, from the MRI of 67 asymptomatic patients that were conducted, they were able to demonstrate abnormalities that are consistent with lumbar disc degeneration in 34% of those aged 20 to 39 years, 59% of those aged 40 to 59, and 93% of those aged 60 to 80 years, portraying the import of age as an important factor in the etiology of lumbar spondylosis. The prevalence of degenerative lumbar stenosis increases with age. Among those aged 60 to 69 years, mild stenosis have been found in approximately 50% of them, while more severe findings were present in 20% of asymptomatic subjects. Degenerative spondylolisthesis is common in people who are above 50 years. And there's a sex predilection when it comes to degenerative spondylolisthesis. 2.7% of males have been found, the incidents have been described as in 2.7% males, while in females it was up to 8.4%, according to a Copenhagen osteoarthritis study. For pathophysiology, lumbar spondylosis is primarily a disease of the intervertebral disc. As an aging intervertebral disc usually develops small tears in the annular range, into which the nucleus pulposus, which is the semi-solid central contents of the intervertebral disc, herniates, weakening the annulus. Sustained axial and translational forces on the intervertebral disc will further weaken the annulus fibrosis, causing it to bulge or even extrude its semi-solid content. Now, the nucleus pulposus, as it loses its normal physiological architecture, will break down, and sometimes they are resolved. The disc commonly herniates posterolaterally, because that is where it is mostly weak, compressing its lateral nerve roots. Central herniations can also occur into the spinal canal, compressing the spinal cord or the corda equina. Now, with progressive degenerative disc changes, its lobe bearing and spine flexibility functions begin to rest on the other joints, especially the facet joint. This will result in osteoarthritis of these joints that will manifest as scapular laxity, subluxation of the facet joint, and enlargement of the articular surfaces, which is thought to be a compensatory mechanism as an attempt to provide stabilization, which the disc can no longer provide. Now, osteophytes will develop from the end place of the moving vertebral bodies as they move over each other with the absence of a degenerated intervertebral disc. The osteophytes, the bulging intervertebral discs, the hypertrophy or partial subluxation of the facet joints all together will cause central canal or foraminal stenosis, which will in turn result in neural compression. The mechanism by which compression of the neural elements induces neural dysfunction is not clearly understood, but possible mechanisms that have been described include mechanical damage, vascular insufficiency, and inflammation. Now, as the disc space is narrows, the ligamentum flavum folds inwards in a process called buckling. It's hypertrophied, and less frequently, it can calcify, further compressing the dural sac. Stenotic changes are most prevalent at L4, L5 level, followed by L3, L4, and then L5, S1. There's no generally accepted criteria for lumbar spinal stenosis diagnosis, but it is generally accepted that a spinal canal diameter of less than 12 millimeter is to be considered stenotic in most cases. Genetic and anatomic factors are the main contributors to degenerative spondylolisthesis. For genetic factors, we talk about spinal bifida occulta, or some individuals that have first degree relative with degenerative spondylolisthesis. Facet joint that are sagittally oriented at L4, L5 level, then associated with an increased risk of degenerative spondylolisthesis. One study suggested that a facet with a greater than 45% sagittal orientation at this level, L4, L5, it has a 25% higher risk of degenerative spondylolisthesis. Increased incidence of degenerative spondylolisthesis in females, just as I mentioned during the discourse on etiology. It has been attributed to greater ligamentous laxity and hormonal effects, as it has been found that the facet joint of postmenopause women have greater expression of estrogen receptors. Degenerative spondylolisthesis occurs most commonly at L4, L5 level, followed by L3, L4, and then L5, S1, just like we found. For the grading of spondylolisthesis, it is graded according to the percentage of the spondylolisthesis, and the formula for calculating percentage is the length of listhesis over length of vertebral body times 100. If the percentage of spondylosis is less than 25%, is grade 1. Grade 2 is when it's 25 to 50%. Grade 3, 50 to 75%. And grade 4 spondylosis is when it's 75% to complete. When the spondylosis is more than 100%, that's when the vertebra above is lying by the side of the one below. It's actually called spondylosis. These are my references. Thank you.
Thank you, Dr. Chukudima, for your presentation. Very succinct and apt. We would now like to take the second presentation from Dr. Raphael Nshin. Participants could do well to drop questions in the chat box, pending when we get to the formal question session. Thank you very much.
Good evening, sirs. Standing on the already established protocol, I will continue the discussion with the presentation, evaluation, and management of lumbar spondylosis. These are my outline. By way of introduction, lumbar spondylosis is a degenerative disease of the spine that affects the intervertebral discs, vertebral end space, facet joints, ligaments, and neural foramen. And this results in lumbar spinal stenosis, neurogenic claudication, radiculopathy, and mechanical lower back pain. There are risk factors to this disease. There are some modifiable and some non-modifiable. Like as the previous presenter explained, age from 40 years and above, there's increased risk of patients having lumbar spondylosis. Then equally said for males, mild and moderate diseases are actually more common in males, while females usually have more severe diseases. Then obesity, because of the axial loading on the spine, it predisposes the patient to having spondylolisthesis. Then smoking, because of the microvasculopathy, equally increase the risk of spondylolisthesis. Then the classification can be anatomical or clinical. For anatomical classification, we have central canal stenosis, which is when there is narrowing of this central canal. We have lateral recess stenosis, when this lateral recess, the height is less than 2 mm. Then also have foraminal stenosis, when there is effacement of the epidural fat covering these nerves. So clinically, the patient can present with radiculopathy, neurologic claudication, caudal equina syndrome, and low back pain, and mechanical back pain. So for lumbar radiculopathy, actually results from compression of nerve roots. And so the patient usually presents with radiating pain that is usually dermatoma. Also present with sensory radiculopathy like paresthesia, anesthesia, hyperesthesia. And there are also motor weaknesses and also hyporeflexia because of radiculopathy. Therefore, mechanical low back pain actually results from destruction of the structural integrity of the spine with accompanying vertebral body collapse. So these now increase the stress on the supportive and stabilizing tissues of the spine, including the muscles, tendon, ligaments, and joint capsule. So here the patient presents with localized lumbar pain that is worsened by activity and relieved by rest, and also associated morning weakness. The neurologic claudication is actually the hallmark for lumbar spondylosis, and it results from the narrowing of the spinal canal and also the neural foramen, with resulting ischemic pain. So here the patient feels pain while walking, just like in our patients that we presented that has a progression distance of 20 meters. But when the patient stops and sits down or flexes the spine, it now opens up the spinal canal with also the neural foramen. So the patient will feel relieved when the patient stoops. And this now makes them to have this shopping cart sign. That is, as they're moving, they tend to bend forward to help open up the spinal canal for them to have less pain. Then there are some red flags that once you see, you need to admit this patient and work up for surgery. And they include when there is progressive weakness, then also signs of caudal equina syndrome, which includes shadow anesthesia, bone and bladder dysfunction. So for evaluating this patient, the pain character is very, very important because we need to know, differentiate it from other things that can cause claudications. So we need to know what really relieves this pain. Is it flexing or is it just stopping while walking? They also want to know the walking distance, the functional limitations to these patients, and other treatments that patients must have undertaken. So for examination, when the patient is entering your clinic, you need to shake the posture because most of the time they tend to stoop so as to feel less pain. But when a patient is coming in with like a degenerated lordosis, it's very unlikely to be lumbar spondylosis. Now, on palpation, you can feel some tenderness and some muscle spasm. And then detailed neurologic examination, focusing on the motor using the Royal Medical Research Council of grade 10 scale, where grade 0 is no movement and 5 is full power. You also check the sensory examination using American Spinal Injury Association scale, which can either be absent, diminished, or normal. Then you also check the reflexes using the National Institute of Neurologic Disorder and Stroke scale. In lumbar spondylosis, most of the time, patients will have either absent, diminished, or normal reflexes. When a patient starts having exaggerated reflexes and with clonus, it's unlikely. It may be that the patient has a tandem stenosis, maybe cervical or thoracic, or may have a brain lesion that's causing the hyperreflexia. Because in this case, it's usually hyporeflexia. Then this table actually shows some clinical presentations of specific nerve roots involvement. Like previous presenter stated, L4 is usually more involved. So here, the knee jerk will be reduced. Then also knee extension and ankle dislocation will be weakened. Then the patient may have paresthesia or pain radiating at the medial leg and foot. Then some other nerve root tension tests that are important include the raised leg test. This helps in differentiating between hip pain and sciatica. Then for femoral stretch test, it's usually positive when there's lesion between L2 to L4 level. Then tendinopathy test also tests for L5. Then there are differential diagnoses to this pathology. One is vascular claudication. Here, the patient also has claudication, but when the patient stops, the pain tends to reduce, unlike in neurologic claudication, the patient actually has to flex, either sit by sitting down or lying down and flexing the spine. Then for metastatic disease, the patient may have maybe a patient of that may have CA prostate, CA renal CA, or may probably have carcinoma of the breast, thyroid, lungs. Then for peripheral neuropathy, it's like usually seen in a patient like that has diabetes. Then also of hip pathology, vertebral fracture and infection, all differentials. Then there are some important things to note. When you start having hyperreflexia, it's unlikely that a patient has lumbar spondylosis. Also, when a patient has painless motor deficits, or when the sensation that is affected is not dermatoma, it's unlikely to be lumbar spondylosis. Then X-rays are usually the first line of investigation because of its low, that is cheap. Then here you look out for osteophytes. Then there's usually narrowing of intervertebral disc space. Then we also measure the diameter of the lumbar spinal canal, like by checking the distance between this posterior, the location of the posterior longitudinal ligament to enter laminar line. So usually when it's less than 11 millimeter, the patient has severe lumbar spondylosis. X-ray, you can also diagnose spondylolisthesis, and oblique films can show us past defect. Then we can also check for instability. Here you take a lateral X-ray view, a neutral, then flexion and extension. So when there is more than a translation of more than 3 mm, or when there's angular changes of more than 10 to 15 degrees, it shows that the spine is unstable. So meaning that for doing treatment or doing surgery, it needs to be fused. Then magnetic resonance image is actually the gold standard for diagnosis, because here it shows the disc degeneration, canal stenosis, foraminal stenosis, also shows the ligamental flavum hypertrophy. Like here, there is neural foraminal stenosis. Then body and leg grading scale for lumbar stenosis. Here, we use an axial view of a T2 image, axial view. So you have grade 0 to 3. So for grade 0, there's normal, the thecal space is intact. There's no compression of the thecal space. You see the CSF, then you see the nerve roots. Since the patient is lying down, they will oriented posteriorly. They also check the lateral recess. So for grade 1 is normal. For grade 2, there is partial effacement of the thecal space, but you still see there's still some CSF, and still the nerve roots are still discernible. Then for grade 3, there is complete effacement of CSF spaces, but the nerve roots are still discernible. But for grade 4, the nerve roots are not discernible anymore. Then computed tomography and computed tomography myelogram can also be done But most of the time is when you can't actually do an MRI, like when the patient has an MRI incompatible pacemakers and they call it baclofen pump. So you can do CT scan and you call it CT myelogram. So CT can equally be used when you are planning to instrument to shape the pedicle, the width and length of the pedicle, to know the type of pedicle to the type of pedicle screw to order for. Then you can also assess bony stenosis. It can also help in making the use of CSF leaks. Then there are also some measurements that you can do using the CT, like you can measure AP diameters, which is supposed to be at least more than 11.5 millimeter. Then the lateral recess can as well be measured using CT scan. If it's less than 2 mm, it is diagnostic of lateral stenosis, lateral recess stenosis. Then CT scan can also identify calcification of posterior longitudinal ligament and ligamentum flavum. Then electromyogram can be done and left consultant studies. Here in lumbar spondylosis, usually normal. Used to differentiate between lumbar spondylosis and other peripheral neuropathies. Then bone density evaluation can be done using the dual X-ray absorptiometry. Here, especially if it's postmenopausal woman, you are thinking of osteoporosis and you're planning on instrumenting the spine. You may need to shake this to make sure that the bone density is adequate and that can take your screws. Then for the treatment, the goal for treatment is to assess the neurologic involvement and the degree of the involvement, and also to sufficiently decompress the neural elements to preserve and restore the neurologic function, preserve and restore spinal stability, and to control pain. So here we use both multimodal and multidisciplinary team approach. Usually the first contact is usually the primary care physicians that see these patients, manage this. They can also manage when you're doing consultative care. Then after the surgery, also refer back to primary health physicians. Then the neurosurgeon, spine surgeons operate on this patient. Neuroradiologist helps with the imaging. Then pain specialists and physiotherapists are helpful during consultative care. So for mild diseases, usually the first line of treatment is non-operative. Here you educate the patient on weight reduction to reduce the axial loading on the spine. Then activity modifications, they can recommend them on physiotherapy to improve their strength, flexibility, and core strengthening. Then for pharmacological management, you use non-steroidal anti-inflammatory drugs, acetaminophen, steroids. Then you can equally use short-term opioids so as to prevent dependence. Then muscle relaxant like baclofen can equally be used. Then since the patient may be depressed from their pain, chronic pain, amitriptyline can as well be used. But treatment here is actually individualized. Then a study by James and Wentner on surgical against non-surgical treatment for lumbar spondylosis actually shows that by 2 years, patients operated, like treated surgically, actually fare better than those treated conservatively. Then there are also some interventional pain procedures that can be done. These can actually be both diagnostic and therapeutic, because if you inject a particular, maybe a facet joint or a particular nerve root and patient's stop feeling the pain, is diagnostic, so that if you are doing surgery, you know that if you do that surgery at that particular level, that the patient's pain will be okay. Then also the patient can actually be pain-free for up to 3 months. So there are some modalities that we can use there. You can either inject steroids through the interabdominal space to the epidural space. Then you can inject the facet joint, and equally can inject the nerve root. Then radiofrequency ablation can also be done. Then there are indications for surgery. When there's failure of conservative treatment, then also when there is progressive neurologic deficit, when you are still doing conservative treatment, when the patient has initially present with severe stenosis, when the patient presents with scoliospinal syndrome, also when there's significant functional disability, there are indications for surgery. And the goal of surgery is to relieve pain, halt progression of symptoms, and possibly reverse some existing neurologic deficit. So there are some surgical options. We have decompressive procedures, which can be direct or indirect. In direct decompressive procedure is laminectomy so as to increase the space and decompress the nerves. But in the indirect, you can do either posterior lumbar interbody fusion, anterior lumbar interbody fusion, translaminar lumbar interbody fusion. The aim is just to increase the space to reduce the compression of the caudal equine. Then this decompression can be done with fusion. Then we can also have minimum invasive techniques. So there are factors to consider when to know the procedure to choose. So when there is severe central canal stenosis, especially when the disc height and neural foramen are preserved, we prefer to do a direct decompression. Because in indirect decompression, most of the time they try to distract the disc space in order to increase to decompress the neural foramen and also the spinal canal. Then there are indications for fusion. When there is spondylolisthesis of more than 25%, then also when there is dynamic instability on dynamic X-ray, then also when there's risk for destabilization following surgery, like when you're doing the transforaminal lumbar interbody fusion, usually we will take down the facet joint. So taking down the facet joint, once anything affects the pars interarticularis, that's fine. Usually it's rendered unstable. So when you plan on doing this approach, you also plan on instrumenting. Then when there's multiple recurrent disc herniations, you also plan on instrumenting. Thank you. So for surgical principle, the aim is to decompress the neural elements, restore normal alignment, stabilize the pathologic segments, and also prevent further deformities. So preoperatively, these patients are usually middle-aged and elderly patients, so they may also have some comorbidities like hypertension, diabetes. So you work up the patient, making sure the patient is fit for surgery. Then you review your images, knowing whether the symptoms the patient has is correlate with the images, so that when you do the surgery, the patient will feel relief. Then if you don't have the implants in your center, you have to contact the vendor and tell the vendor the particular procedure you want to know the implant to bring. Then you get the consent. Then follow strict aesthetic condition for the surgery. Then anesthesia is usually general anesthesia. Then the patient is position prone. Then approaches, if you are doing an open procedure, most of the time you approach it midline, but if you are doing a minimally invasive, it's off midline. Then dissection has to be meticulous to prevent excessive muscle bleed. Then we usually use intraoperative images like CM, OM to localize where we are. Then also intraoperative neurophysiologic monitoring is also used in this patient. First is that you first take a baseline using somatosensory evoked potential, motor evoked potential. Take the baseline. Then after decompression, there should be an improvement in the nerve functions. Then also during the surgery, if the amplitude reduces, it also allows the surgeon to know that maybe where you're putting your screw, you may have to redirect your screw. Then use of image manipulations like microscope and loops is quite important here. Use of implants, wound closure and drain. And this picture of T-arm and O-arm. So here also radiolucent table is important so as not to hinder your images. Then post-operative pain control, DVT prophylaxis and early mobilization is quite important for this patient. Then for the operative procedure proper, here you start with your surgical safety checklist to make sure that you are operating on the right patient and also at the right location. Then general anesthesia is usually GA. I use a cuffed endotracheal tube so as to prevent kinking of the tube during surgery. Then use a patient preoperative antibiotics and use thromboembolic deterrent stockings. Then patient is like for position, the patient is laid prone. So you use abdominal cushion to make sure that the abdomen is free, so as to prevent increased epidural bleed. Then we also flex the legs. Then also use pad the pressure points, also pad for the face. Then after, if you don't have this cushion, you can just use a bolster on the chest and pelvis. Then after this, you have to break the table, like you have to flex the spine to increase the interspinal space, because this actually makes the surgery easier. Then after that, you localize the space you want to work on using your CM or OM. Then you infiltrate your incision site with lidocaine adrenaline. Then you prepare the site and drape the patient. Then for normal laminectomy, here you give a skin incision, longitudinal skin incision on the skin, subacute and thoracolumbar fascia. Then you now use your monopolar diatomy to do a subperiosteal dissection. You dissect the muscle of the spine and the lamina, with your limit being this facet joint, because you won't want to affect the capsule of this facet joint, because this can now render the spine unstable. Then, Then when you are done with that, you use your bone runger to remove this spine. Then use your kerosene runger to excise this lamina bilaterally, still limiting at this facet joint. Then when you're done with that, you also use your kerosene runger to remove the yellow ligament. As you are removing it, you see that the compressed dura with the collar equina will be relieved. Then tracing, as you continue removing the ligamentum flavum laterally, you decompress this lateral recess. You compress the lateral recess. Then if there is hypertrophy of the facet facet joint, you also do a medial facetectomy. But you have to make sure not to violate the pars interarticularis, because once it's violated, the spine will remain unstable. Then when you are fully decompressed, you can use your hook or a left hook to shake the nerves, see that they are fully free, that they're not being compressed anymore. Then also your neurophysiologic monitoring will also show that the nerves are now functioning better. Then if the spine is stable, you can close up. Then there's also another option, like if you want to do a bilateral decompression through bilateral or unilateral laminotomy. So for this is for you use it when the AP diameter is normal. So here you can decompress. Okay, here if you are incising, just incise the skin, subacute, thoracolumbar fascia. Then when you get to the spine, you only open one side, and also the lamina, still limiting yourself to the medial facet joint. Then after that, you can use your kerosene runger or drill to remove the lamina of one side. Then you can either leave your ligamentum flavum or you can remove the ligamentum flavum of that side. Then, but you have to leave the ligamentum flavum of the contralateral side. You now use a diamond drill so as not to injure the neurovascular structures, to drill the undersurface of the spinal process and also the lamina of the contralateral side. Then when you are done with that, if there is hypertrophy of the facet joint, you also do your medial facetectomy. The limit when you need to know that you've actually fully decompressed is that you should see the medial aspect of the pedicle. You need to see the medial aspect of the pedicle on both sides. Then also you can equally see the lateral aspect of the dura. That shows that you actually completely decompress the nerves and corda equina. Then if you need to fuse, like if there is an instability, and how you enter up, you can as well shake the spine by using your bone runger to hold the spine and move it up and down. If there is excessive movement, then you know that the spine is unstable. Or if peradventure you injure the pars interarticularis, so you now need to fuse. So here you use your left foot to retract the bone, the dura containing the corda equina, retract it to one side. Then you incise your posterior longitudinal ligaments, then incise the degenerated intervertebral disc. Then you remove the disc. Then also prepare the end plates by creating the end plates. Then after that, you now bring your cage, your spacer. You bring your cage and put them. Usually we used to put them left and right. Then you now put your pedicle screws. Use your O-arm or C-arm to confirm your position. Then you now put a rod. The rod usually, if it's operating on the lumbar spine, you put them in lordosis so as to help maintain the normal anatomy. Then these are the discs that we can use. So another important factor here is that those bone shapes that we brought out during the spine, that is when we remove the spine and the lamina, you can add them to these discs when you are replacing. This actually encourages new bone formation and fusion of the vertebrae. Then there are some other approaches. We can as well use anterior lumbar interbody fusion, oblique lumbar interbody fusion, then transforaminal lumbar interbody fusion. Here, we actually take down the facet joints. So here, once you are planning on this, you have to also plan for instrumenting. Then when we are done with this, we irrigate the wound. Then you can put your vancomycin. Wound drain may or may not be used. Then you close the thoracolumbar fascia, close the subcute and the skin. Then give the patient adequate pain relief, give prophylaxis and mobilize patient early. Then currently, people are actually tending towards minimal invasive surgery because here most of the time we don't really we separate the muscles, we don't really dissect them. So this results in low post-op pain and reduced mobility, and also there is reduced blood loss and transfusion rates, and the patient may actually be discharged the next day or even the same day. So we have two types: use of tubular retractors or use of endoscopy. Endoscopy, the most common is actually biportal, although uniportal endoscopy can as well be used. So for use of tubular retractor, that is microscopically, you take your pre-op images. Then here you sound the bone, localize the interlaminar window. Then you now put your dilator serially to dilate the muscles because you don't really want to cut the muscles. Then before you now put your tubular retractor, then you target the interlaminar window, which is away from the midline, like 2 cm away from the midline. Then after that, you attach the tubular retractor to the operating table. Then if you are working on the ipsilateral side, just as I discussed during the laminotomy, unilateral laminotomy, here you angulate the tubular retractor 5 to 10 degrees to the midline. Then you now separate the muscle, take out the lamina and the ligamentum flavum. Then when you are done with one side, you angulate the retractor 20 to 25 degrees so as to work on the other side. That's but from the same space. So you now angulate it to work on the other side. Then during drilling, it's noted that if you are drilling on the right, you go clockwise, but if you are drilling on the left, you go anti-clockwise. Then you also have to, when you to know that you already achieved total decompression, you have to palpate both the pedicles, medial end of the pedicles, to show that you've actually completely decompressed the nerves. Then for use of endoscopy, especially biportal, because there is one port is for the endoscope and also irrigation, while the other one is for the working instruments. It's usually faster with less mobility. So here you still take your pre-op images, then you still, just as I explained during laminotomy, after removing the lamina and the ligamentum flavum, you decompress to make sure you've gotten the medial border of the pedicle. Then you can as well do even discectomy using this approach. Then post-op, the incision scars are usually small when compared to open surgery. Then also interspinal process devices can as well be used. Here, you put a device between the spinal processes so as to prevent extension. So keeping the spine like flexed so as to open up the spinal canal. But there are some contraindications, like if the patient has severe osteoporosis, if you put it, it can actually fracture the spinal process. If the patient has the spondylosis, they are actually worsening. Then when there is stenosis associated with synovial cyst, most of the time it arises from the facet joint, although it can also arise from ligamentum flavum or posterior longitudinal ligament. When you arise from the facet joint and you are planning on removing it, most of the time, since you remove the facet joint, plan on instrumenting. Then tandem stenosis is when you have stenosis both at the cervical and lumbar, or thoracic and lumbar. So here you make sure you check the predominant symptom the patient has and know the main one to operate on. Then this is a Swedish study, a randomized control trial that compared fusion against non-fusion, just decompressing without fusion. So they checked by 2 years and 5 years. They actually noticed that if there is no instability of the spine, that there are no statistically significant difference whether you instrument or not. So they used Oswestry disability index. So this is actually functional questionnaire where you ask the patient 10 questions, grade them 1 to 5. So you have a total of 50. If you multiply by 2, you get 100%. So 0 means there's no problem, 100 means the patient is. The complication that can arise from this treatment is one is smoking, hypertensive. Then you can have instability, but you have to prevent it by making sure you didn't violate the passing pathologies. Then adjacent segment disease usually occurs in patients after some days because you really fuse a particular place, a particular segment of the spine. So the lesions adjacent to it actually is predisposed to having spondylosis later. And that includes epidural hematoma implant failure. So the prognosis actually because the severity of symptoms at presentation affect the prognosis. Then also duration of symptoms. If the patient has had this for years, they are usually they have worse prognosis. Then for the post-op course, up to 70 to 80% actually show clinical improvement after surgery. 15% shows no improvement, while 5% actually are worsened. So in conclusion, lumbar spondylosis is actually a progressive degenerative disorder. MRI remains the gold standard for diagnosis. Conservative treatment is first line, especially for mild diseases. Then surgical decompression remains the gold standard for symptomatic stenosis with physiologic compromise. Then fusion should be reserved for instability and deformity. Treatment should be individualized using clinical and radiologic findings. These are my references. Thank you.
Thank you very much, Dr. Raphael, for the presentation. I think you've done justice to most of the key issues in lumbar spondylosis. This session now would take questions and it goes in the chat box. While I'm doing that, members, especially our senior colleagues who are present on the meeting could do well to indicate by a raised hand before they ask questions. A couple of questions in the chat box. I think the first question here is, thank you for the presentation of what genetic spine deformity within methods I think that is not in keeping with the topic. And the next question is, what are the various forms of exercises one can do to conservatively manage lumbar spondylosis, and can it be prevented? If yes, what are the preventive measures? So what are the measures to prevent or reverse this condition? Another question is lumbar spondylosis co-managed with, I think that should be orthopedic surgeons? Then does lumbar spondylosis affect children and infants? How is it managed differently from adults? Are there complications to the surgery of lumbar spondylosis? I think some of those have been listed. And what are the success rates of surgeries for lumbar spondylosis? Then do other studies agree with that surgical management gives better outcome in the long term? And then after numerous physiotherapy sessions with symptoms persisting, what should be the next line of management? So those are the questions from the chat box. With the presenting team will definitely answer these questions. The floor is open to questions from the house. Are there any questions you would like to pose to the presenters? That would be welcome at this point. Okay, so the presenters could do well to start answering the questions in the chat box.
Thank you for comments. The first question, you say ways to detect and manage the genetic deformities. abnormalities to prevent rapid progression of disease. Sorry, I think the question is not clear. I don't really get the question. Therefore, the exercise to manage the lumbar spondylosis, flexion extension exercises, that is muscle strengthening exercises by the physiotherapists can actually help these patients in strengthening the muscles to help to reduce the pain of these that this illness is caused. Then we can actually manage these patients with orthopedic team. They operate on the lumbar spine. We also operate on the lumbar spine.
C'est pas. C'est vous qu'elle était sortie quand même voir quand même mon chance quand même voir.
The success rate for surgery is up to 70 to 80% after surgery. Then 15% will not have any improvement, while 5% can worsen. So about other studies, whether it agrees with I didn't see any other studies that's I didn't see any other study that says that surgery is superior.
Okay. I guess there are a couple of new questions in the chat box. So, thank you, sir, for your presentation. For a previously symptomatic lumbar spondylosis and existing malignancy without spinal involvement, how do you explain the progressive lower back pain? Okay. Is it safe to say that existing malignancy aggravates asymptomatic lumbar spondylosis? And does surgery help this patient, especially when there is no neurologic deficit or neuronal deficit affecting the bladder or bowel? Maybe Dr. Chukudimma could have a go at that.
Okay, for the first part of the question, that's whether a previous asymptomatic lumbar spondylosis, if there's malignancy, but without spinal metastasis.
Yeah.
And spinal metastasis can as well cause back pain by either it can cause mechanical back pain by destroying the bones. Then it can also cause radiculopathy. Sorry, I'm not too sure of this. I'm not too sure of the question.
Okay. I think maybe more senior members could help with some aspect of this question. Then another question is, what are the causes of pain in degenerative spine disease? I think that's what Dr. Chukudimma.
Okay, they're asking of the causes of pain in degenerative spine disease. Okay, just like I presented, the mechanism by which the compression causes pain, neuronal dysfunction is not very clear currently, but it's still an area of much research and but the possible mechanisms by which lumbar spondylosis could cause pain is, number one, there is compression of the neural elements, they call the equina, spinal cord. And because of that, such compression, inflammatory processes could take place. And we know that one of the hallmarks of inflammation is pain. So when the nerves are inflamed, yes, there could be signals of pain sensation sent to the brain and to the uh, and uh, and to the other areas that will interpret the sensation as pain. So another mechanism could be from mechanical damage, which will also lead to inflammation and uh, disruption of the neural elements. So these are some of the ways that that compression of the neural elements can cause pain, and mainly through the inflammatory process. That's what I can say.
Thank you very much. Without much ado, would like to introduce the faculty for today, is none other than Associate Professor of Medicine, Dr. Kaunda Ibebuike, who is a consultant neurosurgeon at the Imo State University Teaching Hospital. He's also a spine surgeon who had done a fellowship at the University of Cape Town and the Good Score Hospital, all in South Africa. As a mark of excellence, it also be necessary to point out that he is a dual qualified surgeon, first bagged the fellowship in general surgery from the National Postgraduate Medical College of Nigeria, and then proceeded to a neurosurgical training in South Africa, where he also bagged the fellowship. Currently, I'm associate professor at the Imo State University. So, personally, I'm happy to present him to this forum today. I think there could be no other fitting faculty for today. I would like to invite Dr. Kaunda Ibibrike, our faculty for today, to deepen the discussion and also help us out with some of the areas that are contentious, both from our knowledge of the pathology and the discussions we've had so far, especially from the chat box. Welcome, Dr. Kaunda Ibibrike. Happy to have you, sir.
Thank you very much. Please, can you hear me?
Very well, sir.
All right. It's been a very interesting and detailed presentation. I think the presenters have done justice to the topic. And as if I knew that that would be the case, I had to look at a different approach with regards to the topic, so that I will not basically repeat a lot of what has already been said. So I'm just looking at an approach to lumbar spondylosis and sciatica. So basically, when you see these patients coming with their pains, what do you do and how do you go about it? So I will look at this. Let me enlarge, okay? So I look at this under this outline: definitions, pathology, clinical presentation, investigations and management, and then differential diagnosis. So with respect to definitions, lumbar spondylosis is a degenerative disorder that may cause loss of spine structure and function. It's also referred to as lumbar spinal osteoarthritis or spondyloarthritis. Aging is the primary cause. So like someone asks, can it occur in children? In the question section. Well, if you look at it as a degenerative disorder, then it can't occur in children. But if you look at it as a disease that can also be a secondary pathology sometimes, probably to trauma, then it's possible to have it in children. So it increases with age and is considered an inevitable part of aging, and that we should all be aware of. I've actually observed it even in younger patients. And Infection is also one of the conditions that we predisposed to it occurring in younger patients. That is why we need to look at the differential diagnosis as well. Consider them in all this. Heavy physical work, high BMI may contribute. Location and rate of degeneration are individual. Sciatica refers to pain radiating into either lower extremity distal to the knee, and it is most commonly associated with L5 and S1 radiculopathies, which together account for 90 to 95% of all lumbosacral radiculopathies. L4 accounts for less than 5% lumbosacral radiculopathies. The higher lumbar roots make up the rest. Multiple factors result in sciatica in lumbar spondylosis. And then let's look at the pathology. So you have the motion segment, basically made up of your intervertebral discs with the adjoining vertebral bodies. And you know the contents of intervertebral discs have all been mentioned in the previous discussions. So this is what it looks like. And this is what we describe as a motion segment. Behind you have your facet joint, ligamentum flavum, posterior recruitable ligaments, supra and interspinous ligaments, which are major components of the posterior ligamental complex, and which you strive as much as possible to preserve, if you can, when you are performing surgeries of the spine. Now, in degeneration, what now happens is your annular fissuring takes place, the nucleus dehydrates, and then there is also herniation. And then you have your facet hypertrophy, flavor hypertrophy, stenosis, and then PLA degeneration, including osteophyte formation and listhesis. So these all take place as part of the degenerative process that leads to the symptom complex related to lumbar spondylosis. So you have a progressive degeneration from what looks like this, and then to what now looks like this. I'm sure we know about this. Let me not go into details regarding this. And the presentation. The onset could be acute or chronic. And so you need to have this, bear this in mind. And then it could also be spontaneous, or like we said, is there trauma predisposing to this? And then are there also previous episodes? Is it a mid-spinal or paraspinal, flanks, buttocks, or also getting to the legs? The duration could be days or weeks or months. And any new type of pain, is there any new type of pain superimposed on the older one? Severity could be very patient dependent, and it could be even severe in recumbency. And when this is there, it should raise some red flags. And then the pain could present on awakening. You have a lot of patients complaining about that. And it could be non-radiating dull low back pain during the day and even at night. And then there could be associated complaints like fever, night sweat, loss of weight, abdominal or urinary symptoms, pregnancy, organic issues. So this should all be looked into when we are assessing these patients. Triggers, basal type maneuvers, posture or walking, and the motor symptoms like foot slapping when walking, falls due to legs giving way. This should all be also assessed. The sensory disturbances like numbness, tingling, coolness, dysesthesia, allodynia, and the bladder and bowel disturbances such as retention, incontinence, dribbling, and constipation should all be assessed. And when this is present, one should be looking at probably an indication for urgent action. Aspects of examination general examination that we should look at. So we want to assess for anemia, adenopathy, wasting, and fever. So when you have this, definitely you are thinking of a non-benign process. I had a patient that presented last week, and although I saw it was more of low back pain. They came with an MRI that showed a vertebral body collapse at L1. And then I asked them to get set, for surgery. There was compression of the conus medullaris there. And then there was anemia. I think it was 24%. Of course, that raised a red flag that this probably is a malignant lesion. So fever also, you could indicate spondylitis and epidural abscess. So if one is given a history and then mention this low back pain and talks about fever, I had one that presented 23 years after delivery, came back 3 weeks later with pains, low back pain, fever, and all that. And then we did the MRI. There was a spondylodiscitis. So these are some of the things one should bear in mind. The skin lesions, psoriatic arthritis, neurofibromatosis, erythema nodosum, hidradenitis suppurativa, these are all things we should also look at. The abdomen for organomegaly, prostata mass, abdominal aortic aneurysm is a possibility. Rectal for sphincteric tone, anal wing, cremasteric, and buccal reflexes. The peripheral pulses, evidence for against vascular claudication. In fact, I had a patient that I've been managing for low back pain, had surgery, and she kept complaining about these pains in the lower limbs, And I had to now take a history of claudication, and I found that it was actually a vascular claudication I was dealing with. And referred her to the cardiologist to manage, and today she's quite fine. So these are the things we should look at. The neurological examination, we inspect the back for evidence of trauma or deformity or head tufts and so on. Inspect the legs for wasting and fasciculations. Percuss and note for marked pains in tumors or infections. And then also for the posture, listing away or towards pain for the legs, and then stooping or patient stooping forwards. These are also signs that gives you evidence, indication of what may be happening in the spine. Now, motor testing systematically go around each joint, grade power in each area by root values such as L1 and L2 for hip flexion. Sensory testing for pinpricks, most useful, mappadermatones of hypo or hyperesthesia or allodynia. Then don't forget your reflexes, L1, L2, 3, 4, and S1. And then lumbar spine range of movement usually reduced, varies widely with age and individuals, and useful in follow-ups. And then gait evaluation, look for antalgic gait, foot drop, heel toe walking, toe tapping, hopping, which may all suggest weakness, subtle weakness that you may pick up with this evaluation. And then your neuromechanical tests are useful agent to examination, low back pain radiating down the legs. And then there are neuromechanical tests that you can perform, such as straight leg raising test, Lascaux test, Bragg's test, contralateral straight leg raising test, prone straight leg test, Brusic's test, Passava test, Patrick or Faber's test, Water test, and case length test. This can also give an idea of what you may be dealing with, and you may have to carry out these maneuvers. So, investigation and management. Points to consider here. So the lifetime prevalence of an episode of significant low back pain is 60 to 70 to 90% from the study by Robin in 2007 publication. Then lifetime prevalence of an episode of low back pain of more than 2 weeks duration is 13.8%. These are quite old studies anyway, but that's still relevant to us. The poor correlation between spondylosis on radiographs and symptoms is also what we should consider. And I have a lot of patients with this. They present to you, the symptoms are so marked, some of them actually looking suicidal. When you look at the MRI, yes, spondylotic changes, but they do not correlate with the symptoms. So what do you do with these patients? These are points to consider, when you have the patients. Significant percentage of patients with lumbosacral adenocarpathy from herniated discs improve without surgery. And I've had patients like that with obvious spondylosis, disc herniation, and managed conservatively, today perfectly fine. Natural history of acute low back pain favors conservative management. So when a patient presents with acute low back pain to you for the first time, as long as the indicators for surgical intervention are absent, the first line of treatment should be conservative, at least up to 6 weeks, and a lot of them do very well. But I had a patient that came to me, listening to one side, looking at it, obvious disc herniation and all the signs on MRI. But this is an acute presentation. So I put him on medications, came back to me a week later, perfectly fine, until date, perfectly fine. Of course, if one had rushed in to perform surgery for him, he probably will also improve with the surgery. But the improvement may not really be because of the surgery. It may also have been that this patient would have done very well without surgery. So that is why we should also look at this. Better surgical results at 3 months, but similar to medical treatment at 1 year for sciatica. This you can find in the New General Medicine 2007 publication. So what are the red flags when we see these patients? Low threshold for investigation in atypical cases. These are fever, wasting, muscular weakness, trauma, known malignancy, weight loss, recumbent pain, drug abuse, and then sphincter issues. When we notice all these are red flags, and they actually should raise our high index of suspicion. We will be dealing with low back pain that may not be typically due to degenerative disease. And then we can now, go ahead with our baseline blood test and imaging to assess what may be happening. So conservative management, in-depth presentations with non-focal, stable neurological findings should be treated conservatively. Initial bed rest, non-steroidal anti-inflammatory drugs, muscle relaxants, and physiotherapy. Epidural steroids, TENS, acupuncture, facet blocks remain controversial. The aim is to mobilize them as soon as possible. And at this stage, one may not go into detailed investigations. But when the symptoms persist for several weeks or worsen despite adequate conservative care, then we may escalate our care and our evaluation. So where patients present with frequent recurrences of symptoms, and also where there's increasing disability in these patients, we need to escalate our care, we need to escalate our evaluation. And so one of the things I always ask this patient is, how does this symptom affect your daily life? If I have a picture of a distance they will know, I'll ask them, can you walk from here to this distance comfortably? Oh yeah, doctor, I can run. Of course, if you can run, then this pain is not something that should bother, should raise a lot of concern for me, especially, when there is no focal neurological deficit. I will always reassure them and manage them conservatively. But when a patient comes to me and tells me, doctor, I can't even walk from my house to the gate, or a patient comes to me and the patient cannot sit down, the patient is just lying down, of course, then I know that the patient's quality of life has been significantly affected. So whatever I can do to improve their quality of life, I go for it. So those are some of the considerations one looks at to help these patients and decide, what to do with these patients, either for conservative management continuation or to escalate the care to surgical intervention. Where there is no obvious focal neurological deficit or sphincteric disturbances and just having low back pain. So what do we request for? Basic blood tests, plain lumbar x-rays, including weight-bearing stress views, MRI scan, left conduction, electromyographic tests where indicated. And we need to always correlate between the clinical findings and the investigation findings. We always need to correlate them so that, where the correlation is not clear, we'll be able to think further about what may be happening. I saw a patient that presented to me, already booked for a lumbar spine surgery because the MRI of the lumbar spine, which was requested for, and based on his complaint of low back pain, numbness in the lower limbs and everything, showed evidence of spondylosis, disc herniation, spinal canal stenosis, lateral stenosis, all the pictures were there. But this patient, when I was taking the history, clearly mentioned to me that he finds it difficult to stand up and walk. That also the thighs are heavy, so he can't even carry his body. So that raised some, poor correlation between this history is given to me and what I discovered. Okay, the findings in the MRI were from L4 down to S1. Then I did my deep tendon reflexes, elbow jack, knee jack, and they were all exaggerated. So at that point, I told the guy that, look, you have to go and do an MRI of the cervical spine for me. I choose cervical spine because the elbow jack was also exaggerated, which was not my problem, but I chose thoracic spine. I think there's something higher than these lumbar spine changes that may be responsible for your symptoms as well. It may be a tandem kind of spondylosis disease. So, he came up with so many questions because he had been prepared for lumbar spine surgery. He was going for the surgery, but someone now told him, no, come and meet this other person, he did my surgery and I'm fine, I'm driving my car now and all that. So he did a cervical spine surgery. And of course, he showed a C6, C7 disc herniation, spondylotic changes with cord compression. And I told him, look, this is what I think may be responsible for your heaviness in the thigh and your difficulty in walking. It may not be responsible for the other symptoms you have in your lower limb. So I will first operate on your neck And after that, I will reevaluate you and look at the possibility of operating your lumbar spine. So we need to always correlate between these clinical findings and also our investigation findings so that we do not operate at the wrong side. And this is not just limited to our environment. I had a patient that came all the way from overseas with a lumbar surgery, stabilization, pedicle screw fixation. He traveled from Nigeria to the country and had this surgery, and he said when he woke up, his symptoms were exactly the way they were prior to the surgery. He returned to Nigeria, someone referred it to me, and then I was taking a history. And for the history, clearly I could see that his problem was in his cervical spine. But another doctor somewhere had operated on him and operated on the lumbar spine. So I told him, go and do your cervical spine MRI for me, let me see. And when he did it, of course, he had, I think his O was C3 or C4, C5 spondylotic changes with disc herniation and cord compression. He had surgery for that and his condition improved. So we should always remember this very significant. In terms of surgery, the compression of neural structures, which has been well explained to us by previous presenters, stabilization of unstable motion segments, realignment of the spine, several approaches to the compression and stabilization disease. Our second speaker really went to town on this. And the correct patient selection, the correct surgery by the correct surgeon is vital. Now, when the second presenter was presenting a lot of those beautiful images of, the compression and everything, using high-speed drill, I would just say, I hope people will not look at this as a very simple thing to perform. It can be devastating. Extremely, if even the high-speed drill, you need to learn the technique of how to use it. Otherwise, if you're using the high-speed drill and you see yourself drilling through the dura and drilling nerve roots. So these are all things you need to learn. It doesn't just, you don't just look at pictures and look at the pictures and you feel it is easy and then you practice it. You will damage patients' spines or nerves. So it must be the correct patient whom you have selected, and you offer the correct surgery and make yourself the correct surgeon so that the patient will be better off, and that will also increase confidence patients have in spine surgery. So the management basically is summarized, starting with bed rest, analgesics, NSAID, bracing, walking aid physiotherapy, can escalate to epidural injections, rhizotomies or facet blocks, and the major surgeries which indicated for instability, significant stenosis, major disc herniations. Issues in management, patient expectations versus realistic goals. Always speak to your patients and educate them very, very well. Let them appreciate what you are going to do for them. I've had patients that I was not willing to operate on them because of how severely spondylotic their spines were. And then when they keep disturbing me, doctor, are you running away from me? I call them, I said, look, you have a very bad spine. The kind of surgery you need for your spine is very, very extensive. And these surgeries does not even eliminate pains. You have pains now, your pains will also persist after the surgery. So I need you to appreciate that and understand that. But if you are willing for me to improve your quality of life, reduce probably the pains, not that your pains will disappear, then I can try something and look at the most simple procedure I can perform for you to achieve that for you. So before the surgery, the patient appreciates what I'm going to do for them. They appreciate that I'm not trying to eliminate pain. I'm trying to improve their quality of life. I had one recently, and when I met him on Tuesday this week, he was so happy. When he came to see me in the clinic, between the gate of the hospital and the OPD, he can spend like 30 minutes struggling to walk. But he came in on Tuesday. How are you, sir? Doctor, I'm okay. Doctor, I'm well. Doctor, the excitement, the happiness. Of course, his pains are still there. His pains are there. He pointed to except for this leg that is still giving pain. But he can now walk a longer distance. Probably, I didn't watch him, but he was overwhelmingly happy. So patient expectation is a realistic goal. You need to look into that. The influence of available options. You need to also consider this. Sometimes, except in emergency situation where you know that an urgent intervention will be limb saving for this patient, functional recovery for this patient, and then probably whatever else needs to be perfected, you can refer the patient to another expert who can, perfect what should be done for the patient. Otherwise, if there is time, if it's not an emergency, you shouldn't go into what you don't have the best option for the patient. You shouldn't go into it. Because these patients, we always believe that whatever you are going to do for them will solve their problems. So don't always opt for the available option if there is a better option that can be offered to the patient elsewhere and the patient can hang on and receive that. The adverse outcomes. Always have in mind that these surgeries can make or mar you as a spine surgeon. They can make or mar you as a spine surgeon. Because when you have adverse outcomes with these patients, they will spread your name. When they will spread your name. Who did your surgery? In fact, some patients, you find patients who come to you with low back pain. When you want to talk about surgery, they don't want to hear about it. And then when you ask them why, my friend went to this doctor and this is what happened. I had a patient that his own classmate, a Nigerian surgeon, traveled to one of the Western countries for his spine surgery. Of course, he didn't believe in our system in Nigeria. And after the surgery, he died. He didn't come out of it alive. So he now developed his own lumbar spondylotic issues. I remember that he is a gynecologist, that his own friend died overseas. And so since he can't go to overseas and have this surgery, of course, he didn't even consider it at all. He called me, I approached him. He told me, Kana, look at my MRI. I'm having so much pain at my lower back, but please don't mention surgery. Why? Because when I asked him why, my friend went to, of course, once you give me such as part of your history, I will align with you. So I looked at this. I know he needed surgery, but I aligned with his line of his mindset. It's okay, take this, take that, take this. Some months later, he called me urgently. He can't walk. The pains were not so excruciating. It was quite difficult to walk, to mobilize, And when I met him, I asked him to repeat the MRI, and I told him how. Chief, you need surgery. At this time, he accepted the surgery, not because he still believed that, or he now believes that we can do a good job for him, but because he cannot walk, it has reached that stage. And I looked at him and I looked at my schedule and I told him, okay, can I book you in the next 2 weeks? He said, no, why? He can't wait, he can't wait. He can't wait. So I had to book him, I think 2 days after we met. I did his surgery. 3rd day, I discharged him. 4th day, I went to meet him. He was sitting down eating, the wife beside him, and this man was blessing me. I never knew that this procedure can be performed in Nigeria, not to talk of here in Owerri. And you have been suffering with it for years. So you can see how much adverse outcomes can affect others who may get to hear about it. But like I said, it can even mar you as a spine surgeon because they will spread the information about you. Oh, don't go to this guy, don't go to this guy. That is why selecting your patients is also very, very vital. So what are the differential diagnoses when we look at lumbar spondylosis and they present to us? Degenerative could be disc disease, it could be spondylosis like we are talking about. Inflammatory could be sarcoidosis or vasculitis. Neoplastic could be primary metastatic or carcinomatous meningitis. Endocrine metabolic could be diabetes, osteoporotic fractures, Paget's, acromegaly, congenital, so many and so much to think about, to rule out, to consider. Arachnosis, synovial cyst, spondylolisthesis, becoming syndrome, vixenation, vertebral fracture, osteomyelitis, epidural abscess, tuberculosis, and brucellosis, and even dural and intradural arteriovenous malformation. So much to consider when this patient presents to us with low back pain, and probably what we'll be thinking of is, could it be spondylosis or could it be something else? Thank you for your attention.
Thank you very much, Dr. Kawande, our faculty for the day. I sincerely appreciate how well you handled this session. You've ended up answering most of the questions in the chat box. And I think that just affirms the fact that the faculty was well chosen. I would waste no further time than to also immediately recognize very senior members of the medical community who have joined us in this seminar to also contribute to the development of spine surgery as much as we are discussing this. In particular, I would like to recognize Professor Temitayo Shekumbi, a doyen of the specialty. You're welcome, sir. I'd also like to recognize Professor Jibo Abdullahi, who was on the call earlier. We also recognize and appreciate your presence, sir. Same goes to Professor Biodun Ogumbo, Professor Shubode, Professor Tayo Ojo. You are all very, very well appreciated for turning up for today's seminar. Special thanks and recognition also goes to friends of the neurosurgical community, Professor Ogun, Professor of Neurology, who has consistently graced our programs. Also recognize Dr. Bede Azudialu, very senior family physician practicing who has also joined us. Special recognition also goes to Dr. Jiu Mexi Kabulu, the Young African Neurosurgical Forum chairperson. You are all welcome to this meeting. We would like to hear a word or two from the very senior members of the community, as this would represent fetching knowledge from the deepest layer, and would appreciate if we could be so blessed by them. Thank you very much. So you're welcome to the floor that is open now for your contribution. Okay, there's a comment from Dr. Bede Azudialu in the chat box. Thanks, Dr. Kaunda, for the lecture. I don't envy neurosurgeons with respect to spine surgeries as you expressed. Clearly informing the patient that by expectations is key to patient satisfaction and litigation avoidance. I've seen patients operated abroad and come back worse. Secondly, I'm convinced that we family physicians should refer our patients with low back pain to neurosurgeons and not orthopedic surgeons. Now that they are readily available, what do you think? I think this is directed at Dr. Kaunda, and your reaction to this would be very much appreciated, sir.
Yeah, thank you, Dr. B. Azudialu, for your for your comment. I don't know if I should say you should refer your patients with low back pain to neurosurgeons and not orthopedic surgeons, but the few cases of poor correlation between signs and examination findings has been from, I'm not castigating orthopedic surgeons, but has been for orthopedic surgeons. That is my observation. And even the patient I told you about who was operated in the Western world, in fact, in the United States of America, so it was an orthopedic surgeon that did his surgery. So I don't know why that happens. I don't know whether for the orthopedic surgeons, because they are not neurologists, so it's like they see the image and they manage the image. And why we, the neurosurgeons, we take our history and we try to correlate the findings from the history with the image, and we're able to think through to guide us and make sure we give even the patient that I told you was about to have a lumbar spine surgery, it was also an orthopedic surgeon who was about to operate on him. And for me to convince him that, look, if you want, I can operate on your lumbar spine. It's not an issue for me, but I don't think it will solve your problem. Go and do the cervical spine MRI and let me look at. Of course, I told him too that the cervical spine MRI will also show me the thoracic spine from the whole spine sagittal sequence. So eventually he got convinced and I did the surgery. He's gone back to wherever he came from. So I cannot categorically say you should refer your patients to neurosurgeons. I personally do not discriminate. Once you are a spine surgeon, I am comfortable to refer my patients to the spine surgeon. But most of the time, I will also discuss with them. So if a patient needs a kind of a referral or want to go to another place, closer to his home or relatives, and I'm to speak with a spine surgeon, I don't, kind of discriminate. If I feel the person I want to refer to is an orthopedic surgeon, I will call him, speak with him, tell him the case I'm sending to him, and that is it. So I don't think it would be right for me to say you should refer to only neurosurgeon. But then you are correct, probably in your environment, since most of those involved in spine surgery are neurosurgeons, yeah, you can refer to them in your environment. But we amongst ourselves as spine surgeons nationally, we also know whom we can refer some cases to if we want to. I mean, if I have a deformity case that I do not want to perform, I think most of those I know who are very strong with deformity surgeons are the orthopedic surgeons. I will call whoever of them I wish to refer the patients to and refer to them. That is the way I look at that question.
Thank you very much, sir, for your response. I think we've dealt with the range of questions that were available. But also, at this point, like to equally thank you for taking out time to grace this seminar. At this juncture, I would like to gradually wind down on my own participation. And I would like to say that I've been reminded of some of the key issues, especially with respect to the psychological profile of the patient and establishing a therapeutic alliance that deals their expectations reasonably. I think part of the fears that I've encountered has been outcome and on our own path, the fear of litigation. Thank you very much, sir, for today's participation. I also want to thank every other person who has been on the call. At this point, I would like to hand over proceeding back to Dr. Maiwa Para, the YNNF chairperson, to conclude formalities for this month's installation of our webinar series. Thank you very much for your time, and thank you for having me lead and moderate the discussions today. I'm grateful.
Oh, thank you so much, Dr. Ndafia. That's excellent moderating today. We really appreciate you. I want to really appreciate our faculty for today. Dr. Kaunda Ibibe became my boss for so many years now. It was not a mistake to have you on as our faculty today. We knew you were going to be able to teach us so many things, and we appreciate your wealth of experience and the knowledge you have imparted us. It was a very long webinar today. Lumbar spondylosis is not a small topic at all. And I want to appreciate our two residents for taking time to really dissect through the issues. That was a very brilliant way of presenting. And thank you so much. There were so many questions that we would have wanted to take. There are so many questions we would have wanted to take, but the time is really against us now. So I want to appreciate every single person for being a part of the webinar today. Thank you to all of our seniors who came around, who joined us for this presentation. Professor Shokumbi, Professor Ogun, we appreciate you once again. And our orthopedic surgeons who came in to join. Thank you so much. Orthopedic is also a part of spine. Quite a number of orthopedic trainings have spine as part of their training, and so they also are able to handle spine very well too. So thank you so much for joining us in the presentation today. We appreciate everyone. And to all of our colleagues who came from outside Nigeria, we appreciate you. Dr. Kabulo, my boss, thank you for joining in today. And before I round up, I just want to remind us that tomorrow is another time to have another excellent webinar by the Young African Neurosurgeons Forum. It will be 5 p.m. Nigerian time. So please join in to learn some more. We'll be talking about pituitary macroadenomas. Please join us tomorrow. And thank you everybody once again. To all of our YNNF ESCO, thank you for being part of the presentation tonight. Thank you everyone. See you again next month, last Friday of the month, our webinar time. Thank you and bye-bye. Okay, to get links of other webinars, just come to, you type Young Nigerian Neurosurgeons Forum on YouTube. You'll be able to be a part of all of our previous webinars. Okay, thank you everybody. Good night.